This is not a test. Stay calm in an orderly fashion. Make your way to the lifeboats.
Mayday, mayday, the ship is sinking.
All right, ladies and gentlemen, thank you so much to our Friday podcast, of course, where we do interviews. For those of you who are listening, this is a really awesome person that we get to interview this week. We are interviewing yet again another doctor. We're so privileged to have her. She is just a juggernaut in the many things that she's doing in the community, and I'm so excited to hear about her plans and what she has going on. But without further ado, ladies and gentlemen, Dr. Jennifer Hoffman.
Thank you for having me.
Yes. So I think right off the get, I would love to hear and for you to tell our viewers, who are you? What do you do?
So I'm Jennifer Hoffman. I'm a physician in the OB-GYN field, which means that I take care of women in all stages of their lives related to pregnancy and not pregnancy. I've been in practice for 20 years. I went to the University of Michigan Medical School, and then I did my residency training in Allentown, Pennsylvania. I settled there for several years, and then because I grew up in Michigan and you always go home again, I moved back to Michigan, first Kalamazoo, and now I've been in Lansing for the last 5 years. Yeah.
Awesome. So as far as I know that you've had quite an extensive career. Currently, what are you doing? What have you done in the past? What is your passion?
So most recently, I worked at Sparrow Hospital in Lansing. I am formerly the chair of the department of OB-GYN and the quality director. And we started a women's service line at Sparrow Health, which is kind of a new concept in the way to take care of women.
Good stuff. Good stuff. So in that women's concept, that's how I got to know you. Would you speak a little bit to what is this women's concept? What were you really focused on, and how were you measuring your goals?
Right. So at Sparrow, what we were trying to do is shift the focus from how hospitals organize themselves into doctors and nurses and administrators and patients, and instead think about how the patient enters the health system, which is the service line concept, because a patient or a client doesn't really care when they come into the hospital which department they're going to see. In fact, if you had a nosebleed, you wouldn't know which department to call. You just know that you have a problem. So the women's service line concept is, how do women enter the health system, and then how do we take care of the problem, team approach. So it has more to do with how, if a woman comes in to the health system with breast cancer, for example, how can we make care for that client easier and more accessible?
Wonderful. So in your just amazing practice and the things that you have going and the things that you had started, we had come to know each other specifically through the substance use disorder field. So I'm wondering if you can talk a little bit on what your view is of substance use disorder, how you kind of got roped in, and how we met.
Right. So I'm not in recovery myself, but I have family and friends that are, and my family has been hit by the tragedy of an overdose death. And so that is where my personal interest came from. When I was working, before I lived in Lansing and Kalamazoo, I participated in a citywide project that was related to neonatal abstinence syndrome, which is when women are pregnant and they have a baby with substance use disorder, the baby can stay in the hospital for an extra period of time with neonatal abstinence syndrome. And some amazing social workers in the Kalamazoo area decided to create a community approach for children that were born with NAS, and how can we provide community resources. So that's where my passion started. And then when I moved to Lansing, we met because we decided to ultimately apply for a grant from Blue Cross Blue Shield to provide women's health care to women with opioid use disorder in pregnancy and not in pregnancy, and to make that care accessible. But the really most impactful thing that we did was not get the grant from Blue Cross Blue Shield, it was make the relationships. So it took us 2 years, I think, of meeting all of the people in our community who in that service line concept can come together around a client to make her life better when a woman has substance use disorder. And so we started meeting with hospital pediatricians and social workers, but then we learned about people in the community, like community social workers and peer recovery coaches like yourself and Deb Smith. And we the most important thing that we did was create those community relationships, because I think a lot of doctors like me think that healthcare only happens inside the hospital, when really the most important things that you can do for someone's health happen out in their homes, in their communities, and at their schools and at their jobs.
Absolutely, absolutely. So in your, in your long and extensive career, you said that you really started to see a lot of this pop up, especially around case management. I'm wondering if you can talk a little bit to what you initially saw, what made you engage with I believe the neonatal alcohol syndrome or the substance use disorder with pregnant mothers.
So as an OB-GYN, I deliver babies and I take care of pregnant people. And so a lot of my initial experience was in taking care of women with substance use disorder who would come into the hospital, and really nobody knew how to address those issues. And sometimes when they do address those issues, it's in a judgmental way. And I had a lot of personal problem with that, because I have concerns that we in the healthcare industry are actually more biased against people with substance use disorder than we are against some people with of color. And I wanted to make changes in our healthcare bias. And so because of that, we needed to start reaching out to people in the community to learn more, because honestly, a lot of people in the healthcare field, even though we're really good at taking care of pregnancy and delivering babies, just were not good at the medicine of addiction. And so we had to learn about it, honestly. And so the best way to learn about it is from the clients themselves, and from people in recovery, and from medical experts in the field. And so that's, where Dr. Burke and I started pursuing our passion for learning more about addiction medicine as it relates to women's health, because we're trying really to create a comprehensive and not judgmental team to offer the best health care for women.
Wow. So there's a lot there. Now you mentioned right towards the end there, the comprehensive team. I'm wondering if you could unpack that a little bit. How do you see it as a comprehensive? Because obviously yourself as an OB-GYN, you're focused primarily on the women health and with the baby, but what else is inside of that comprehensive team?
Yeah. So one of the best things about women's health is the team approach. And I never want to see that change in women's health. I think that labor and delivery units across the country have that nailed. The doctors and nurses are very good at working together in emergency and safety situations. As it relates to pregnancy and the problems that can happen during labor and delivery of a baby. So I think that we need to expand that team of the doctor who takes care of the pregnant mother, the doctors and providers who take care of the newborn baby, the nurses who are on the team of labor and delivery, and the social workers who are aware of community resources that are so important when someone has a baby, because you need so many things: good housing, electricity, water, transportation, and stuff like car seats and baby beds and diapers. So women's health was already good at that sort of team concept, but we just were not good at approaching addiction that way. And so I think we need to expand our team to allow for example, rooming in of mothers when their babies have to stay in the hospital for a little extra time for treatment of neonatal abstinence syndrome. We need to expand to physical therapy and occupational therapy and music therapy, so that we can expand the amount of resources that are available in a non-judgmental way.
Well, and I think the key word there is non-judgmental. So how do you see the stigmatization of women who struggle with substance use disorder and who are also pregnant? What have you seen in your field thus far, the stigmatization or maybe destigmatization towards those women?
Yeah, my concern, as you know, Christian, is that the problem is that we're still struggling in medicine and politics to see addiction as a disease. And the truth is that we're never going to get rid of the stigma until we can identify addiction as a disease that needs lifelong treatment. And I think a lot of people in the healthcare field and doctors like me still consider addiction a choice. And you know that there's plenty of evidence out there to show that that's not true, that there are brain changes in addiction that mean that it absolutely is a disease that needs medical treatment. And we in the healthcare field need to start acting that way. It's like a doctor telling a client, just choose to not have diabetes, just choose to not have high blood pressure. And until we can come together as a society and realize that this is not a choice, it requires treatment, then the stigma is going to remain.
And I think there's no better way to kind of springboard into that, especially around stigma. You know, I know from my personal experience in the field, there's different stigma towards different drugs and what people are on. But I'm wondering if you could talk to kind of the astronomical rate of babies being born with THC in their system, and what you as a doctor are seeing, what you feel that the field should be pursuing, and how those conversations need to be happening next.
Yeah, I think the problem is that we just don't know enough about it right now. And so I think it's really hard as a society in our current practice of legalizing marijuana to really tell people about its effect on pregnancy and newborns when the data is not all there yet. The truth is that they've done some studies about newborns when they've been exposed in utero to marijuana, but not followed them to school age. And so we don't really know what it's going to be like at age 5. When clients come to me and say, but I can legally use marijuana, and so I want to during my pregnancy, I say, well, you can legally drink Jack Daniels during your pregnancy. It's still not medically recommended. And so just because things are legal doesn't mean that they're necessarily healthy.
Sure, sure. Now, I know from your past experiences that you did quite a lot of hands-on education, that you had quite a lot of students who are coming into the medical field, and you had hands-on at least a part of their education, if not being able to teach them a lot of things. So I'm wondering if you can speak to your experience of having students experience substance use disorder in pregnant women for the first time.
Yeah, I think that I think it's an important experience that everyone needs to have. And I think that my hope for students of the future is that everyone will have some amount of addiction education in their training, no matter what kind of healthcare professional they end up becoming, because the problem is so pervasive in the United States that everybody needs education. I think that the basis of education should be in trauma-informed interviewing, so that we can start approaching people like human beings. The way that we think about it is everybody wants to do a good job every day. And if you just start approaching humans wherever you go, really, at McDonald's, wherever you go, people just really want to do a good job every day. And if you start with some trauma-informed interviewing techniques, then hopefully someday our learners will also have some medication-assisted therapy training, so that along the road of education related to addiction, we can also teach people what medications to use for the treatment of addiction, so that everybody will be comfortable with it.
Wow, fantastic. So just a quick note, especially with you're talking about medication assisted therapy and treatment, what is one of the most difficult things that you've seen thus far as talking to women who are utilizing that for their health while at the same time being pregnant?
Yeah, so this is the amazing way that you and I met, actually. So one of the really hard things about medication assisted therapy is the way that we in America have set it up is the state funding makes methadone treatment programs completely separate from all of the rest of healthcare. And so because of that, it's created these silos of communication, so that until recently, until we started talking, nobody knew what went on in methadone treatment centers. It was like this black mystery box. And what we found out in our 2 years of communication planning to get our grant from Blue Cross Blue Shield is that it's not a mystery. All of the directors and the providers at methadone treatment facilities and all of the family medicine doctors who prescribe buprenorphine or Suboxone for medication assisted therapy want to talk to the doctors who deliver the babies. We just didn't know how to do it before. So I think that the future is really creating that network of communication, so that the clients don't feel like, when I'm in this building, I get this care, and when I'm in this building, I get this separate pregnancy care. Sure. It feels like everybody's taking care of the whole person.
Yeah, and that's absolutely right. So you said a little bit earlier, and I wanted to maybe explore this a little bit more with you, but you were talking about like art assisted therapy and things like that. How do you feel that those things play into maybe a better understanding of a wider set of a medical model? Obviously, we have the medical model, and it's kind of like, let's check a bunch of boxes and make sure that certain goals are met. But how do you see kind of those abstract things like art therapy playing into that medical model?
Well, I think what is amazing and new in medicine is that we know, as we talked earlier, that addiction is a disease of the brain, and the brain is changeable. And I think that the old way of thinking when I was in school years ago was you treat diseases with medicine like pills and surgery. And a lot of us have been stuck in that mindset. But the truth is that there's a lot of other ways to change the brain. You can actually change the way that the brain works by changing behavior, which is what you work on, right? All day long, which
incrementally, but yes.
But if you go to bed at the same time and you get up at the same time and you do a body movement or you drive to school the same every single day, then after a while, you don't have to think about the directions of how to get to work or school anymore. Your body just does it. And that's important. And that's how art and music can help with treatment, is using different parts of our brains can actually heal the brain and create new maps that need changing for the disease process to get better.
Awesome. So kind of going back into the student talk and you being a teacher, what are some things that you recommend for students who are experiencing substance use disorder? What are some things that you recommend maybe that they look into, whether it be, I don't know, a TED Talk, YouTube video, or literature to read?
Well, this podcast, obviously.
Hey.
Anyone who needs help should reach out to their local community resources, often available through their health department or community mental health. Obviously, the internet has lots of information, and some of it is good about who to turn to. And then obviously finding peers that are in a similar situation. So my concern about the future of women's health, my fear is that there won't be enough funding politically for mental health or addiction treatment in the future, because we continue to not think about depression or substance use disorder as real diseases. So I think that as long as our funding through the federal government remains active, then there will be a lot of resources for people who reach out and need help.
So along that line of kind of the fear inside of women's health and SGD disorder related, how do you see us having to approach some of those wider macro level issues of the funding, of destigmatization? What do you feel should be kind of our next steps in the right direction?
Well, you and I are in Lansing, Michigan, so at least it's the capital of the state. So I think that advocacy with our state legislators is really important. I think that we need to show that we are on the side of human beings with substance use disorder because it's a disease. And we have to stop saying us and them. It's all of us. And the opioid crisis in Michigan affects all of us in this community. It affects how healthy we are. It affects how busy the ER is. It affects jobs. It affects, the university and how it functions. So we need to start thinking with our lawmakers about how it's a community crisis, and it affects every single one of us personally.
Wow, absolutely. So I asked this to Dr. Burke. I definitely want to bring this question up with you. What do you feel is the most important piece of information for somebody who is coming into this field, or for somebody that is in this field currently? What do you feel is the most important information, piece of information, and what do you think is the most important piece of wisdom? So maybe it's something like they really got to focus on self-care or whatever it might be, but something that they're not going to learn in the classroom.
What do you mean?
So what do you feel is when they're coming into this field, it's one of those, you just have to learn this? Like, it's not a matter of you're not going to be taught this on paper. It's something that you have to carry out day by day. What do you think that should be for them?
So one of the main things that students need to learn is that this is a team effort, and everybody's opinion on the team matters. And that was hard for somebody of my generation, because this is the thing I had to unlearn, is that the doctor was always right. And we did a lot of independent learning back then. It was like the beginning of self-study in medical school. So you would just sort of go to the library and read, and you could watch your lectures on a tape recording, but you didn't really have to interact with people to learn healthcare. And it's so not true. It's so not true. The doctor isn't always right. And the doctor doesn't have to be this captain of the ship. And the hierarchy doesn't have to be like the military. Like, there's a captain and people that report to them, because honestly, that's how unsafe things happen, is when people don't speak up and tell the captain that something's wrong. And so I think the most important thing coming into the healthcare field is that everybody on the team is important. The client is, their opinion matters, and the nurse and the environmental services people who clean the room matter, and the people who deliver lunch matter. And so I think that's really important.
Yeah, absolutely. So kind of switching back to the rhythm of speaking specifically to women's health, how do you alleviate the, I'm sure, massive amount of stress of a young lady, she's pregnant, she's afraid she's going to get in trouble because CPS is going to get involved or whatever it might be. How do you alleviate that stress? How do you approach her?
What Dr. Burke and I have been saying is that honesty is the best policy. So truthful and open communication is never bad. It really just is not. And having your network of people behind you, and what I mean by that is having your, for example, methadone treatment providers talk to your pregnancy providers and verify that your life is really what you say it is really important. So we don't have control over judges and what they decide in individual jurisdictions, and I certainly can't speak for them. But what I can say is that they love when you're honest, and when you're just trying your best to get through the day and deal with the stress of expecting a baby and making a home that's ready for it. Talking about it is the best thing that you can do. So if you used yesterday, just tell us, and we will not act like jerks about it. And people might visit your house, and that is truly scary, but it's only because there's more than one client now. There's you and the tiny little client, and we just want to make sure that everybody is safe. I think those home visits are stressful, but I think if you're trying your best and you want the best for your family, then you don't have anything to worry about.
Yeah, absolutely. So how do you, is there a different way that you navigate a process with somebody that's addicted to heroin versus somebody that might be on medically assisted treatment versus somebody struggling with alcoholism? Is there a different way that you approach each and every individual?
Yeah, I mean, you have to, but I think that the thing that is united in all of that is the motivation to make a change. And that's where I need help sometimes from my peer recovery coaches, because I use my recovery coaches on my team to do motivational interviewing. unfortunately, not everybody is ready to make a change. And so if I have a pregnant client who is actively using heroin or methamphetamine, I will ask her, are you ready to make a change? And if she's not, there's nothing I can do. There is nothing I can give her
Yeah.
to make her want it. So that's hard. I think that's hard for healthcare providers because we want there to be a pill for everything. And this is not that kind of disease. You really have to put in the work. And I mean, alcoholism is our most classic example of that. It is widely available.
Mhm.
Widely available. So it's like trying not to eat food ever again. I'm going to need you to stop eating food.
Yeah.
And and so you really have to want to do it.
Yeah, yeah, absolutely. So would you say that there's an in particular skill that you try to impart in the students that are serving under you, that it's like, once again, you're not going to learn this in a classroom, but you better get real good at it real quick?
Yeah, I think that they teach us a lot to not share personal experiences, but I do. I mean, I share personal experiences, and you know, I have an 8-year-old son who's virtual learning, and so I'm a mom. I bring a lot of that to the table. I teach that to students. You can use your personal life experience to frame how you feel about this encounter. But when a client is using and they are not ready to make a change, a lot of times their behavior can be erratic or angry, and that can make you feel angry. And so a lot of what we need to learn that is hard for new and young students is our emotional intelligence, how to professionally keep our own feelings in check and still share our personal experiences without getting angry when our client is angry.
And I imagine that that is very difficult sometimes, to not immediately be knee-jerk reactive to that anger. As somebody that has done work in the hospital and other places, you know, it is immediate, and it's just it can be off-putting. It can happen
And you
fairly
can
quick.
feel yourself, like you can feel yourself getting like warm and your pulse is racing and you're like, I'm getting angry. But
Yes.
if you're aware of that, you can start to control it over time. It's hard.
And it's I can definitely say, you know, whether we like it or not, the internal the automatic responses of you know, fight or flight are immediately like starting to bubble up, and it's definitely something that has to combat. So I know you on a different place. We talked about kind of how we met. I'm wondering if you're willing to talk a little bit about the initiative related to the bus.
Yeah. So weirdly, the most impactful thing was the 2 years of meetings before we applied for the grant, because that's where our community resources really came together and started talking. For example, Dr. Burke, who you met, and I thought that methadone treatment centers around town were in competition with each other, like Speedway and Shell gas
Mm-hmm.
station. And we thought that they like wanted to not talk to each other because they were competing for clients.
They
And so
got
none of
better
that is true.
communication than most in the field. I mean, as
Right.
far as medical communication, they're talking daily.
Right. They have it nailed. So it's not like Sparrow Hospital and McLaren are like in competition and their ERs rarely speak or whatever. It's the opposite of that. Everybody wants to talk all the time. So so obviously that was the most important thing. What we were having trouble with is not communicating inside and outside of the hospital. So if a client came in with methadone treatment, we had no way to verify her daily dose. And if she was in the hospital for whatever, appendicitis, and she had to stay a couple of days, we have to give that dose in the hospital, and we didn't even know who to call, but now we know all the people. So that was the most important thing. So then we wrote an application for this grant to provide women's health care at the site of those methadone treatment centers. And we thought that that was really important because a lot of times our clients are driving around town or taking a bus all over town to these like billions of appointments. So a lot of times you have to go first thing in the morning to have a methadone dose, and then you have to go take your kids someplace, and then you have to go to court for some reason, and then you have to go to your prenatal visit at your doctor's office, and it's a lot of travel. So what we were trying to do is make healthcare more accessible by bringing women's and pregnancy healthcare to the site of the methadone treatment centers. And so that was an amazingly great idea. But what we found is that COVID happened, first of all, and that was not great timing. And second, that we had trust issues still. So even though we had built relationships with the providers and the resources and the social workers and the peer recovery coaches in the community, the clients still didn't 100% trust the doctor in the parking lot of the methadone treatment center, which is understandable. But I think with time, that could have gotten better. It's just COVID. So.
Yeah, the greatest excuse in the world, COVID. Well, I think that's a perfect point to bring the elephant up in the room, which is COVID. So how do you see the women's medicine maybe have changed during COVID? What are some things that you are really excited for? Because I know COVID ended up manifesting some things that's like, well, that's interesting. And it also made some things like, well, maybe we can't continue to do that.
Right. So all the bad stuff about COVID is pretty obvious. So the way it's really changed treatment for pregnancy in the hospital is it's limited the number of support people that you can have with you. And that's really hard. And it's especially hard in addiction. So sometimes you really need your support system around you when it's hard to do the best job you can do every day. So they're still limited. It's getting better. You can have 2 people visit in the hospital right now. And obviously we're still working on rooming in moms with their babies when their babies need to stay. So space is still a challenge. What is good about COVID is a shorter list, obviously, but we turned on telemedicine like so fast in the blink of an eye. And when we talk about the mobile unit and access to healthcare, telemedicine is also access to healthcare. We have all heard in the state of Michigan about the closing of maternity units. In some cities, women are needing to drive an hour in labor to have a baby, and that is not acceptable. We want to expand access. Access for addiction is also very hard, especially in the northern part of Lower Michigan and the whole Upper Peninsula. There are just not enough healthcare providers like me and Dr. Burke who are interested in women's healthcare and in a non-judgmental approach to substance use disorder. So telemedicine is what's good about COVID. I think we can not only help clients through telemedicine, I think we can help doctors and nurses. And when they have, and we can teach them about trauma-informed interviewing and motivational change interviewing. And we can do that without needing to travel. So that's the good thing.
Well, I think that's a perfect way to springboard. I know of some details of things that are going to be manifesting hopefully in the future. But what is your grand vision? What is something that you're dedicated to see happen before you're done, and you retire?
Yeah, so obviously I'm passionate about women's healthcare. You can tell. from talking to me. I think that there are not enough people in women's healthcare that are very, very comfortable with substance use disorder. So Dr. Burke and I have talked about becoming board certified in addiction medicine in the future, which involves a lot of learning and patient contact hours, and then taking a big exam and then renewing that board certification on a yearly basis. So hopefully within the next year.
So pretty easy, right?
Yeah, what, like it's hard?
Yeah, it doesn't take time, right?
So it's like studying for any other exam, like a real estate exam. And I'm sure that we can do it and we can motivate each other to do that. But not only is that helpful for us to provide a better service to clients, but it helps us teach the next generation of women's health providers about addiction issues and how to approach them, because we don't want people to be afraid of this anymore when people come into the hospital and have a baby and have your healthcare providers just look lost and afraid of you. We don't want that. So ultimately, when I was working at Sparrow, my big career vision is to improve access for women everywhere. I envision a women's ER where women can go with any stage of pregnancy or any women's complaint and be seen by knowledgeable healthcare providers and get comprehensive healthcare. So you've heard of pediatric ERs or mental health ERs. I think there should be a women's ER.
Yeah, and I'm very, very excited to see that. So, I would be remiss. I'm going to be a little bit selfish. I'm a new dad, right? So I just had a baby, and what is some information that you think? Because I know oftentimes OBGYN, you're hyper focused on the mom, you're hyper focused on the child. Oftentimes the dad are sitting there, I know I did, kind of dumbfounded, a bit like, where am I supposed, over there? Am I supposed to sit on here? Do I sign that? No? Okay. So what are some things or some information that you think would be important for dads to know about this process?
Yeah, I think what's important for dads is that a woman is in charge of her own body. I think empowering your partner to make decisions when it's hard to make decisions, and supporting her is the most important thing that dads can do. I think when we have seen dads get into trouble in the hospital, it's when they try to make decisions for their partner. Like you don't really need an epidural. It doesn't hurt that bad. And or you don't really need to take that pain medicine after that major surgery. I think that dads really need to be supportive, and they need to definitely take a role in the care of the newborn. Dads can do almost every single thing that new moms can do, except breastfeed, but close. And they should do that in a supportive way. The other times I've seen dads get into trouble is by saying, "Oh, this baby sleeps through the night," and the new mom says, "No, you sleep through the night." So I think sharing schedules and feedings and newborn care and being supportive of your partner and the decisions about her body are really important, including birth control or the next baby, or her motivation for making change related to substance use disorder, including quitting smoking, which is the hardest of all, and just help.
It's sweet and simple, right? Help. So before we're finished here, I would really love to. I know that you've got a million different things going on, and once again, I feel so fortunate, so blessed that you're willing to take time out of your very busy schedule to talk to little old me. What are some of the new things that are coming for you? What are things that people should be looking for, and if they want to get engaged with the things that are going on with you?
So right now, I've left Sparrow Hospital. I'm thinking about opening a practice after we take our addiction medicine boards in the next year. Thinking about staying in the Lansing area. Would like to continue collaborating with you, our favorite Dr. Smith, our favorite Dr. Burke, on all things in the future. And in the meantime, we're going to continue with the Ingham County Opioid Collaborative, which is a really great community resource that brings together a lot of people. Their main focus is about overdose right now, which is really important in the COVID pandemic, but it brings together some lawmakers and healthcare providers. We're going to continue to participate with the American Society of Addiction Medicine, ASAM, and their conference is virtual this year, and is always a good networking opportunity, even virtually. So we'll continue to look for ASAM publications, especially as they relate to women and pregnancy.
Well, Jennifer Hoffman, it has been an absolute delight. Once again, thank you so much.
Thank you.
Doctor, you are just fantastic, and we are so appreciative. I have been privileged to see the inner workings of the three doctors, and it's just like, well, I'll be over here if you need me. Whenever you do, just ask, right? But thank you so much for doing this. You are awesome.
Thank you for having me. It's been a pleasure.
Wonderful. Have a good one.
You too.